Thank you very much, Dr. Smith. Ladies and gentlemen, so on behalf of the co-investigators and co-workers, I would like to present you the data of the TOGA trial. The TOGA trial is a very large trial, randomized phase 3 trial that we did in patients with advanced gastric cancer. And just to situate the problem, gastric cancer is a frequent cancer. It's the 4th leading cancer worldwide. There are around 1 million new cases a year of gastric cancer. And it's a second cause of cancer-related mortality because many patients present or will have later in the disease metastasis. The outcome of patients with metastatic gastric cancer is poor. And the standard treatment in this situation is a combination of different cytotoxic, classic chemotherapeutic agents with median survivals usually around 9, 10, 11 months of patients with advanced gastric cancer. And therefore we decided to do a trial, the TOGA trial, also because of the fact that we knew in the meantime that the HER2 receptor, which is a receptor localized on the cancer cell, plays an important role of the growth of gastric cancer cells also and gastric cancer. And also because we have learned also that 22% of patients with gastric cancer, they overexpress the HER2 receptor. And that's similar to what we see in breast cancer. And indeed, we screened, therefore, more than 3,800 patients looking at the HER2 receptor, and we looked at what we call the immunohistochemical test that's looking at the protein, or we did a FISH test that's looking at the gene copy. That's very similar than what we use, what we do in breast cancer. We look also for the HER2 receptor, and then we treat patients with breast cancer with Trastuzumab. So that's the background of the trial. And what we did then is we screened more than 3,800 patients. From those, because we took only the HER2-positive cancers into account for the trial, because we opted for an individualized treatment, like is a theme of this ASCO meeting also. 584 patients were randomized. 290 patients received a combination of 2 cytotoxics, 5-FU or capecitabine. The investigators could choose that in combination with cisplatin. And the other half of the patients received 5-FU or capecitabine in combination with cisplatin, plus Trastuzumab, Herceptin, the HER2, the monoclonal antibody against the HER2 receptor. And when we look at the results, if we can advance the slide. Okay, back. When we look at the results of the trial, the primary endpoint of the trial was the survival. So we wanted to demonstrate that patients who were treated with chemo plus Trastuzumab lived longer. And the trial clearly met the primary endpoint. This is a survival curve as is shown here. And what it tells us is that patients who were treated with fluoropyrimidine plus cisplatin plus Trastuzumab, that they lived significantly longer than patients treated with chemo without Trastuzumab. The hazard ratio was 0.74. This is translated in a 26% lower chance of dying of the cancer when patients are treated with chemo plus Trastuzumab compared to chemo alone. If you look at the median survival, the updated numbers are 11.1 versus 13.8, and I will present these data in detail on Monday afternoon at 3 o'clock. And there was a printing error in the abstract book for ASCO, so it's indeed in the upper GI cancer session Monday at 3 o'clock. These data will be shown, and that's the primary endpoint and the major outcome, so telling us that patients live longer in this setting. We looked also at other endpoints. We looked at the response rate, looking at how many patients had a regression according to the so-called RECIST criteria. And what we saw is that patients treated in blue with chemo alone, the overall response rate was 34.5%. Patients treated with chemo plus Trastuzumab, the overall response rate was 47%. And this difference was statistically significant and is also clinically meaningful. Of course, the question that you would ask is, what about side effects then? Here you can see that there was no difference in the classic chemotherapy-related side effects between the two groups. Trastuzumab did not increase that. What we see sometimes in breast cancer is that patients treated with trastuzumab, they have cardiac problems. In our study, this was not the case. Between 4 and 5% of the patients had an asymptomatic decrease of the left ventricular function. We can explain that by two reasons. One, patients were not exposed to anthracyclines, and anthracyclines may, when they are combined sometimes with trastuzumab, may lead to cardiac adverse events. So that's a clear explanation why this finding was not seen in this large trial. So the bottom line message is that these regimens and this regimen was safe in these patients. So in conclusions, and that's a couple of important conclusions. In fact, trastuzumab is the first targeted agent, the first biological to show a survival benefit in advanced gastric cancer. As I mentioned several times, until now we were treating patients with a combination of 2 cytotoxics, sometimes 3 cytotoxics, but trastuzumab is the first biological, and moreover, we have shown that trastuzumab reduces the risk of death by 26% when combined with the reference chemotherapy, translation of the hazard ratio of 0.74. And trastuzumab, in combination with chemotherapy, prolongs the median survival by 2.7 months, going up from 11.1 to 13.8 months. And I've shown you also and told you that trastuzumab was safe in this setting. And therefore, a key message is that that this is a personalized, the first approach of personalized, individualized treatment for patients with gastric cancer. Thank you for your attention.